morning, everyone. Let's start our gynecology Viva hot seat. Candidate 2. This is a 20-year-old female patient presented with sudden onset of severe, constant lower abdominal pain. Go on. Hello?
Hello.
Hello? Yes,
Hello, sir. Am I audible now?
yes. This
Uh,
patient has sudden severe lower abdominal pain.
so I am presented with the axial T2 MRA pelvis of a 20-year-old female patient presented with sudden onset of lower abdominal pain. I am taking a moment to see through the images and spot abnormality. Um, the striking abnormality I can see is there is a well-defined lesion in the left adnexa, which is of T1 T2 hyperindent signal, and which appears closely abutting the left ovary. And right ovary I can see separately. There is also mild free fluid in the pouch of Douglas. So now I
Yes.
am provided with the sagittal MRI of the same patient. Uh, I can confirm the findings I saw in axial images, and the uterus appear normal with the normal endometrial thickness and junctional zone. The lesion appears to have some a gradient of signal intensities. Sir, I want to know, see the T1 images to next to characterize further.
This is T1.
In axial T1 images, the lesion appears to have a slightly iso-intense signal compared to the uterus. Uh, mm, and
What else?
there appears to have some hypointense signal within the lesion. And
Yes.
in a 20-year-old female with a acute presentation, I would also want to see any twisting of pedicle to see for any adnexal torsion.
Take
Uh,
this one and tell me your final diagnosis.
uh, so this is axial post-contrast images of the same patient. The lesion appear non-enhancing. Um with can I see the T1 FATSAT images also, sir?
This,
Pre-contrast images.
it was the T1 factor. This one pre-contrast.
Yeah, so uh, with these images, I want to consider a diagnosis of a adnexal torsion in this patient because of acute presentation. Uh,
Do you have any clue here for torsion?
uh, the
Do you have any
bilateral,
clue?
okay. I
This
cannot
is,
see.
what is this?
This is right ovary, sir.
Okay.
Yeah,
Where is the
it
left ovary?
left
Look here.
ovary.
I will help you.
Uh,
Do you have any sign of torsion here?
although I am not specifically seeing any twisted pedicle, uh, ovarian stroma also appear normal. There appears to me some decreased enhancement of the left ovary. Uh,
No, the left ovary is normal.
Normal.
I think this one. So, what happened for this cyst? See, this is the left ovary, it is enhanced. So, what happened for this cyst?
Uh, so this can be a benign symbol, benign serous cystadenoma.
Okay, but why the patient have sudden severe pain? Look here. What happened here? What happened?
Mm,
Hmm.
okay.
This
There
is the
is some
cyst.
cyst. Yeah. There appears to have some T2 shading kind of
Mhm.
appearance. So, uh, but in actual T1 images, the lesion was uh, isoindents to the uterus. Still, I would consider a possibility of a endometriotic cyst because of T2 shading signs.
Okay, but see what happened for this cyst. What is the sign of torsion? Did you find any sign here?
Apart from mild free fluid in pelvis, I couldn't find any. And there
Okay,
appears to have some mesenteric fat stranding also, sir.
see, this is the ovary. Okay,
Yeah, here
this is the cyst. What is between of them, both of them? What happened?
there appears to have like some soft tissue twisted pedicle kind of appearance between the ovary and the lesions.
Yes, so what's your final diagnosis?
Uh, uh, with uh, with this twisted pedicle sign and acute presentation, I would consider the possibility of ovarian lesion with the torsion of the cyst. And
Thank you so
this is an
much. Eh,
emergent.
Thank you. It is emergent. Thank you. It is a torsion of ovarian cyst. The ovary itself is still normal, but the cyst itself, why? Look here. No other signs of torsion of the ovary itself. Looks like normal size, no edema, but here there are something abnormal between the cyst and the ovary. This is the cyst, and if you look here, there are a little bit swirling ball sign.
Okay, sir.
Look. Something wrap itself.
Yes.
Wrap around itself. Wrap around itself. Okay?
Okay, sir.
What happened here? What happened here? Look here. This one. This is the pedicle. The pedicle
Yes.
is twisted. But this pedicle not of the ovary. This is of the para-ovarian cyst.
Okay,
Okay?
sir. Okay, sir.
So it is again and again. We see a cyst with sudden severe abdominal lower pelvic pain. Okay, so first of all, search of signs of ovarian torsion. One of the most common sign is to bring this stir and look at the ovary. It must be very edematous. No, this one
Okay.
looks like normal. I think this one's ovary. See, this is the right, this is the left. Both of them not enlarged, not I. See, this is the ovary. But what happened? The cyst itself, follow the cyst, you will see some signal void here twisted around itself. Look, follow this one. This is the pedicle. This, see? Okay?
Yes. Yes,
All
sir.
of this signal void. Best seen here. Very obvious here in the axial. I think this is bowel. Don't think about this one. I think. Or maybe pedicle. Yeah, maybe the pedicle. But the most, this is the cyst. Sorry, this is the ovary. Okay, this is the pedicle. This is the pedicle. I think this is maybe bowel. So
Okay, sir.
follow from the ovary, then something here. Look up and down. It is do whirly ball sign or twisting around itself. Okay,
Okay, sir.
so it is a twisting of ovarian cyst. This one, the black one that you talk about, shading or losing of signal. This bowel. Follow this one. This one bowel. Follow bowel.
Okay.
Okay. So again, my colleague, this is torsion not of the left ovary, but of the ovarian cyst. Next candidate. Next candidate.
Excuse me, sir. This is Dr. Ali. I'm coordinator for this session.
Yeah, welcome,
Can we
Dr.
have
Ali.
candidate 3?
Yes, I'm with you.
Thank you.
Yes, this is, thank you, Dr. Ali. This is 39-year-old female patient complaining of bleeding.
39 complaining of bleeding. Okay.
Yes, go on.
1 second. I'm just
What
should I?
happened? Leave the mouse. Leave the mouse. There's another case.
Okay, I'm
Leave
sorry.
the
I'm sorry.
mouse. 1 second.
Yeah.
This is another case. What happened, doctor? Okay, close it. Anyway, let's take
Excuse me.
another case. No problem. This is 40-year-old. No, yes, this one.
This is,
39-year-old female patient complaining of bleeding. Yeah, go
yeah.
on.
Okay. Should I
Yeah,
scroll
yeah.
or
Yeah, scroll, scroll.
just? I'm afraid I scroll. And it doesn't scroll. Mm,
Use the arrow.
mm,
One
yeah.
second, 1 second. Yeah, use the sidebar.
It's not really scrolling. Yeah, it is now, right? Yeah. Okay, so I'm presented with a T2 sagittal sequence of MRI for a 39 female patient that is complaining of abnormal bleeding. I'm taking my time to examine the sequence. So there is the uterus. It appears bulky, or maybe with yeah, okay. So are there any other sequence I can examine?
And at least you catch one sequence, tell something.
Yeah,
Use
okay,
the
okay.
exam.
So, yeah, okay. So I'm presented with a sagittal 2C sequence of a 39 female complaining of abnormal bleeding. The striking abnormality I can see is multiple lesions at the uterus. There is a fundal, a fundal region. There is a fundal heterogeneous lesion, mostly to T2 hypointense, iso2 hypointense lesion epicentered upon the fundus of the uterus. It shows, however, it shows hyperintense components. It is like okay, it is subserosal. It's exophytic from the uterus, and it is slightly indenting the urinary bladder, the related urinary bladder and bowel loops. There is also, I think there is another one. Yeah, here down at the lower part of the uterus or the cervix, showing the same signal characteristics, hypointense with hyperintense components. The cervix, however, also shows a T2 hyperintense signal lesion. It can be a cyst. Just will have to examine the other if there is like T1 to ensure that it is totally hyperintense cyst. So basically, depending upon this sequence, I'm suspecting these are multiple. I mean, the endometrium sounds fine. If this is the uterus, the endometrium sounds fine. There is no thickening of the transitional zone, I think. Nothing else captures my attention
Okay.
now. So
Okay.
basically,
Look here.
yeah, okay. So this is axial. Just 1 second. Yeah, this is axial T2 of the same patient I'm examining. So this is the uterus with normal thickness. Oh, yeah. Okay, so here it is apparent that the uterine cavity is actually divided. So it's probably not fibroids. The uterine cavity is divided, is a heart-shaped uterine cavity. So it seems like this is congenital malformation of the uterus. The basic differentials, the two ovaries are seen fine, okay? there is one cervix with a cervical cyst probably, and then the uterine cavities are divided. So this is the differential diagnosis of the congenital malformation of the uterus with abnormal fusion or separation. The basic three are the didelphys and the bicornate and the biseptate uterus. This is not didelphys since it is only one cervical cavity, so it is between the bicornate and the septate. However, it is a heart-shaped uterus with a fundal concavity that is more than 5 millimeter and 1 centimeter. So this is likely a bicornate uterus with single bicornate uterus. I should be
What
examining.
else? What else?
What else? I should be examining the vagina if there is a septum. However, I cannot see.
Or look
This
superiorly, please. Look
superior.
superiorly.
Okay.
What happened? What is? Yes, what is this?
Yeah, so at one of the corners, I mean, there is thickening or here, like there is thickening of the is it fibroids? I'm not sure. The myometrium is thickened. The transitional zone is thickened. So bilaterally, the transitional zone is thickened. The hypointensity of the myometrium, the transitional zone is thickened. So this is likely representing adenomyosis. So I think there is adenomyosis on top of the bicornate uterus and also at the
Yes.
thickened hypointense myometrial transitional zone. I think there is like subcentimetric hyperintensities, maybe representing the. I'm not sure. I'm not sure if they are there. Like here, maybe, I mean, so this is probably adenomyosis on top of, on both horns, on top of congenital malformation of bicornate uterus. Explaining the adenomyosis will explain the abnormal bleeding. Adenomyosis is one of the spectrum of endometriosis. So I should be examining if there are any other foci of
So
endometriosis.
what's your final diagnosis?
However, I'm not seeing the ovaries appear normal. I'm not seeing like any. So
What's your final diagnosis?
bicornate uterus with adenomyosis.
Okay. Anything else?
One second, please. I'm trying to. The uterus, the left uterus appears normal. The ovary, sorry, and here is two. There is. If it is adenomyosis, I'm trying to look for the spectrum of endometriosis. However, I cannot really appreciate. I don't know. Are there like hyperintensities here? Or this is in the ovary? Are there any coronal sequences or more sequences I can examine to, or even the sagittal again to, if there is anything extra I can catch?
What happened here? Leave the mouse. What happened here?
This thing or?
Yes, here in this slide.
It is not bowel, right? Yeah. Can I need to. It's not. Yeah, 1 second. So it is
No, don't scroll. Don't scroll.
Okay, like this. Okay. So it is a T2 hypointense lesion epicentered upon the fundus of the uterus. My prime differential will be fundal fibroid.
Thank you so much. Leave the mouse 1 second.
Okay.
So my colleagues, it was a case of multiple pathology. Okay, number one, what happened here? You are examining the coronal, the sagittal, and you find something like this. The best to assess the transitional zone, T2 sagittal. Okay, transitional zone, the junctional zone, the zone between the endometrium and myometrium. It is dark. Why it is dark? Because it is fibrous, mainly fibrous. The endometrium is high T2. The myometrium is intermediate, but this mainly fibrous zone is dark. When you see this large thickness and heterogeneous why? Due to some bleeding and cystic changes, more than 12 mm, it is highly diagnostic of adenomyosis, either diffuse or focal. Second, what is this? And what is this? What is this? Few fibroids. Third, we should go to the axial to see this bicornate uterus. Okay, one cervix, one vagina. Okay, the differential diagnosis didelphys. This is not didelphys, and septated according to the angle. The angle here is very wide. very wide, and it's very obvious in MRI. This is two separate cornea. So it was a bicornuate uterus was with unilateral corneal adenomyosis and fibroid. Okay?
Okay, thank
So
you.
we should also comment on the ovaries. And what else? In any case, my colleague of adenomyosis, try to pick up any endometriosis, even ovarian. So we should look at the ovaries. How to pick up the ovaries? Go follow the iliac arteries or vessel in both sides. Go down, down. I think this one here. And we go here. I think this one down. Sometimes the large ovary obscure, the large uterus obscures the ovary. I think it is this one. So both ovaries are clear. Okay. If you find any endometriosis, try to rule out deep penetrating endometriomas. Okay. I think in the urinary bladder there are something. Yeah, you are correct. Here, I think in this case there are signal abnormality here. Let me check. Yes, here there are some thickening here or signal abnormality here. Okay, in the urinary bladder. Let me check in the answer over here. In the superior part. Yes. Here, this thickening and heterogeneous signal. It
Yes.
may be, it may be deep penetrating endometriomas. Let's check here because I bring one. No. This is just thickening. Why? Because I bring one case with some abnormalities. No any abnormality in the urinary bladder because one friend asked about no any endometriosis in the urinary bladder because originally the ovaries is no both ovaries are normal. So this case was bicornuate with adenomyosis and a few unilateral fibroids. Thank you, doctor. Next candidate. Welcome.
Candidate number 4, please.
Four ready? Hello? 5 ready?
Yes, sir.
Yes,
Candidate 5.
35-year-old male patient presented with pelvic pain and mass.
Sorry, can you scroll for me?
Yes. 35-year-old patient
Yeah.
complaining of pelvic mass.
Okay. I have been presented with MRI of pelvis, axial cuts T2. I can see heterogeneous mass lesion, heterogeneous hypointense mass lesion with central hyper intense area, seen centered on the left to the anterior to the urinary bladder to the left side, and pushing the urinary bladder posterior onto the right side. The mass is seen encasing the vessel, encasing the vessel and extending up into the pelvic brim, pushing the rectum posteriorly. Downward, the mass is seen extending to left inguinal region. I would like to go down to the left inguinal region. On coronal image,
Yes. This is the left one.
I can see the large heterogeneous mass filling the left anterior pelvis and extend into the left inguinal region. I would like to go down and check for the testes.
Okay, clear.
Okay. Okay. Here I can see the left testis, but I
Are you
couldn't
sure
see
this is
the
the left testis?
this appear hyper intense
The signal looks like which
fluid.
signal?
It's look like
Yes.
fluid. Yeah, it's not doesn't
What's
look
your
like
diagnosis? What's your diagnosis?
this is appear as aggressive mass lesion. I couldn't see the left testis, so this is, could be a tumor in undescending left testis.
Yes. Which type of tumors? If
This
understanding
could be a
testis.
this would be a seminoma.
What is your next step?
I will convey finding to referring physician and advise biopsy and workup
Yes.
for tumor and referral for gynecology for oncology MTT.
What is the most metastatic site, lymph node and metastatic site of the seminoma?
Usually it metastasizes to the mediastinum.
No, I'm talking about lymph nodal.
Lymph node will extend upward to the level of the renal.
Yes, where?
Yes.
Where is the site?
Gonadal lymph node.
Para-aortic.
Para-aortic, yes.
Thank you, doctor, so much, because this is a male patient. And it
Yes.
may be some examiner would not tell you, but look here, external genitalia, he is male. And
Yes.
you did very well when you describe and follow. It goes through the left inguinal region, and this is fluid. This is
Yes.
fluid. Why? Look here. Look here. And another point. Testis has a restricted diffusion. Look here. This is the mass. The mass is restricted. This is the urinary bladder. Look down. This is fluid. Through testicular tissue, my colleagues have restricted diffusion. The right testis, this is not our business now. Somebody asked about right testis. I don't know, but see, you are concentrating in the site of pathology. Our candidate have a doubt, is this undescended testis or was complicated by seminoma? She looked down, she didn't find the left testis. So she decides this is cryptorchidism complicated by seminoma, because we need more and more lower sections down to see the testis, the right one. Okay, so the answer here again and again, undescended testis or cryptorchidism complicated by seminoma. Next candidate. Welcome. Yes. So
Okay.
my colleague, my advice from the last case, take care from the 6. Okay, you may be confused or concerned by gynecological cases, or during the exam, case by case by case. Some examiner are tricky and playing with you. Some change or some obscuring of the age or of the sex may change the diagnosis completely. Next candidate, this is 20-year-old female patient presented with left flank pain and mild fever. Go on. Hello?
Candidate 4, are you with us?
Hello, sir.
Yes.
Hello, sir. Can you hear me?
Yes. Again. Okay. Go on.
Yes, sir. So I am presented with the T2 axial sections of the pelvis of a 20-year-old female
Yes.
who's complaining of lower abdominal pain and associated hydronephrosis of the kidney. So I'm just trying to scroll through the sac. I can see, okay. okay, I can see both the ovaries. Sir, actually, I'm unable to scroll it properly, sir. It's jumping the sequences. Would you mind scrolling it for me, please?
Yes.
Okay. So I can see relatively okay. I can see that presence of two uterine cornua. Uh, the ovaries are seen separately, and I can see a relatively well-defined lesion showing internal T2 subtle hypointense contents within. Um, I would like to further evaluate the anatomical configuration of the uterus using the other sequences, if available. Like if there is yeah, and this lesion is up.
What do
Okay,
you think
so
about
there
this
is.
sequence? What do you
Sir,
think?
I can see two uterine cornua, sir, and also I can see that there is a large lesion. I think probably it is a dilated cervix, which is containing some internal heterogeneous T2 heterogeneous contents within. So I actually want to look. So I feel that it is a uterine anomaly associated with the cervical anomaly, like an imperforate or transverse septum within the cervix, which is leading to hydrometrocolpos, that is blood within the cervix. So I want to confirm these findings on other sequences if available, sir.
This one, take this one. What happened?
Yes. Yes, sir. So I can see that, as mentioned in the prior axial sections, there are two separate uterine cornua. There is two separate cervixes also visualized. Actually, yeah.
So,
I can see
what's
that
your
the cervix.
diagnosis?
Yeah,
What's
yes, sir. So I can see that there is a large dilated cervix. So the cervix appears grossly dilated. Sorry, the vagina is appearing grossly dilated with blood contents, which is noted within. So I think it is because of imperforate hymen or a transverse vaginal septum. So that will be type V3 type of malformation associated with Didelphys uterus. And
So,
um,
your final diagnosis, please?
it is a Mullerian or a congenital anomaly which is present in this patient with uterine didelphys, two cervix, as well as a transverse vaginal septum with imperforate hymen, which is causing accumulation of blood products within the vagina. So I would also like to screen and look for other anomalies which is present. That is, if there are any genitourinary tract anomalies or any other vertebral anomalies which are associated with it, because Mullerian anomalies are usually associated with kidney as well as vertebral anomalies also. So I would also like to ask the history of the patient if she's having any severe pain or dysmenorrhea. Um, Also, I would like to correlate with the physical findings.
So, final diagnosis. Give me one final diagnosis. What is this?
Okay.
Yes, you are correct, but give me conclude what you find.
Okay. So I think it is a Mullerian agenesis which is associated with blood within the vaginal cavity, sir. Um,
What
Due
type
to
of this
imperfect.
Mullerian? What type of this Mullerian anomaly? What is the name?
What? Didelphys, uterine
Yes.
didelphys with bicolis
Okay.
and a vagina imperfect hymen with hydrocolpos.
Okay. Which vagina? The right half or the left half? Big difference.
Within the right half, within the right half
Yes.
of the vagina, sir. Yes, sir.
See,
So there is a
so
trans. Uh,
we have يعني right half. This is a didelphys with only the right half which is obstructed. Okay. The right half
yes.
only. This one. Because the left one is here. Okay. The right one is
Okay.
here. Okay.
Hmm.
So we
Hmm.
should mention all the answer. Okay. And this is right in T1 due to hemorrhagic consent. Okay. So this is
Yes, sir.
hematoclobus, not hematometroclobus, hematoclobus, because the uterine cavity itself not contain any blood. I think this is just endometrium. So
Yes.
take care from the anomalies. My colleague, we take till now two anomalies, didelphys and bicornate, and take care from the associated anomalies, associated finding, like here and like the previous case. Okay, my colleagues,
Yes, sir.
is it clear? This case
sir.
was a didelphys with a hemivaginal imperforated hymen, which cause hematoclobus. Next candidate.
Hello,
Hello, yes.
this is
Start,
candidate
please.
4. Sorry, I had a problem with my microphone.
No. It's clear. 40-year-old female pregnant patient presented to the ER with severe pelvic pain. Look here.
Can I scroll?
Yes.
So I'm presented with MRI axial sections of a female patient with abdominal pain. Oh, sorry,
Yes.
it's jumping.
I will scroll for you. I will scroll.
Oh, yeah.
She is pregnant. Okay.
Okay. Yeah. So I can see the uterus appear bulky with gestational sac and the fetal ball inside. Also, the right ovary appears enlarged with cystic lesion,
Yes.
large cystic lesion high in T2.
Yes.
There appears to be a pedicle that's connected to the left ovary. It appears to be twisted as well, and the remaining ovarian tissue appears to be more hypointense than I would expect it to be.
Yes.
So I'm suspecting left ovarian torsion on top of a large cyst.
Okay. What else? Which sequence do you want?
So if there's contrast,
Is it logic to give contrast for this type of patient?
because
Yes or
she's a
no?
pregnant, no.
Yes. Okay. So there are no contrast. So
So can I see T1?
it says T1.
So the previously seen cystic lesion in the ovary appears to be high in T1. So it's probably hemorrhagic cyst.
Yes.
I think this is emergency, so I would convey my findings to the gynecological team for the management.
Okay. Give me some differential diagnosis. What is the possibility of pregnant woman with the nexial lesion like this?
So it could be hemorrhagic cyst, could be
What else?
corpus luteum of pregnancy, but the ovary won't be that enlarged.
What else?
Yeah, could be. Is it ovarian in origin?
Oh no, it's the nexial. What else?
Could be endometrioma.
Okay. How to confirm? What else also? Give me another differential diagnosis.
I can't see any solid component. It's only cystic, I think. Can you scroll, please, sir?
Yes. Do you have any clue here?
I think there is
Could it,
some solid component as well.
okay. Could it be heterotopic pregnancy? Do you know heterotopic pregnancy?
Yeah, to have both ectopic and intrauterine pregnancies in the same time. Yeah.
If I show you this one, what is this?
Yeah, this is diffusion. It shows some
Yes.
restriction. So, can I see the EDC as well?
Consider it restricted. What's your final
Okay.
diagnosis?
So it could be if it's ectopic pregnancy causes ovarian torsion.
What else? Look here.
I'm not sure.
What is this?
Yeah.
What is this dark signal inside the cyst? What is the name of this sign?
It could be a dermoid cyst.
No. This is T2.
Yeah.
What you're saying, this is, what is the name of this sign also?
Shading.
There are two signs. Yes. So this is
endometrioma.
Yes, with restriction. Why does it restrict? If I told you the patient have some fever, for example. So what's your final diagnosis?
I'm not sure, sorry.
Fever and restriction. What do you think?
So it could be ruptured endometrioma?
Infected endometrium.
Infected, yeah.
Infected endometrium. Even if you told, give the examiner some differential like you did, it is very great. Heterotopic pregnancy, one inside the uterus and one extraterine. Rupture, endometrioma, rupture corpus luteum, abscess, because it is restricted. But here, there are dark T2 spot. Dark T2 spot sign in the shading sign. Look, very dark here. And this is not fluid. This is not fluid completely like this. There are some shading. So this is endometrioma. Okay. So finally, it is infected endometrium. Okay. Somebody asked how could to exclude torsion. First of all, by contrast, but this pregnant woman should not be giving contrast. Second of all, follow the vascular pedicle here to look here any twisted vascular pedicle like those. Follow those. Any vessels here around or nearby the lesion here, but I think it is very difficult here. Very difficult. Anyway, this patient is a surgical patient. Second point, in torsion, if you bring the stair, you will see very severe edema, very characteristic edema here, very, very characteristic to torsion. Okay. And some signs will help you because here this is a limited study due to absence of post-contrast images. Thank you so much. Next candidate.
Candidate 7 or candidate 8, please.
I'm candidate 7.
Yes. Welcome. 30-year-old female patient presented with lower abdominal vein.
Sir, can I request for the control?
Okay.
Staff requested.
Go on.
Yes, now I'm able to scroll. Thank you so much. I'm sorry I missed the history, sir. Can you please repeat? Apologies.
Patient with severe pelvic pain.
Have been provided with multi-sequential, multi-planar MRI of a female patient who is in severe, who is presented with severe lower abdominal pain. I'll be scrolling through the given stack of images, which are T2 axial. So I can see uterus is in midline. I could not appreciate any endometrial abnormal signals. The junctional zone appears to be intact and smooth. Images are taking some time to scroll. In the upper areas, I can appreciate a large, relatively well-defined, thick-walled, heterogeneous signal intensity lesion centered within the lower abdominal pelvic cavity, having a large central T2 hyperintense component and peripherally placed T2 hypointense component, demonstrating few focal T2 hyperintense cyst-like areas, predominantly within the periphery. Lesion is reaching up to the upper abdominal visible cuts. It is densely septated in its cranial part with thick internal septations. However, I could not appreciate any other significant solid component. It appears to be within one because of the peripherally located cystic foci. I'm concerned if it's of an ovarian origin. I would like to scroll through the images once again to look for right and left ovaries separately, if visible. So in this particular sequence, I could not appreciate right ovary, and probably the left ovary appears to be placed in the left parauterine location and appears to be normal in this tag, but I will still confirm this on the coronal T2 images. So this is likely pathology arising from the right adnexal and ovarian location. I would like to see it on T1 images as well to look for any T1 hyperintense signals.
So what's your concern? Tell me, tell me from these images, what's your concern?
Either it's a twisted, since there is no significant fluid, but the peripherally placed cystic areas appear like follicles. So this can be engorged right ovary secondary to this twisted right ovarian right ovary secondary to this large intra-ovarian mass lesion. Due to its dense septations and large cystic component, I'm suspecting mucinous right ovarian tumor leading to right ovarian torsion.
Okay. What is your next step?
So I'll reconfirm my findings on other sequences as well. I would also like to look the lesion on T1 and then on T1 post-contrast images to look for any solid enhancing mural nodule.
Here is the post-contrast.
Thank you.
Yeah.
So the lesion has got a solid enhancing component in it, in its cranial over here in its cranial part, with rest of the septations are faintly enhancing.
Yes.
I would also like to take my time to look at any nodal spread, or I could not appreciate any peritoneal nodules, any gross ascites, or any peritoneal thickening.
So what's your final diagnosis, doctor?
So this is a likely a neoplastic etiology of right ovarian origin. Considering the solid enhancing component, I'm suspecting mucinous cyst adenocarcinoma. with no significant ascites, peritoneal spread, or mental caking, or any nodal spread, I will immediately inform the referring physician. This
Doctor, are you
patient needs.
sure? Are you sure this is mucinous adenocarcinoma? Look here at the contrast. Look.
Sir, it is multiseptated with solid enhancing component.
Okay. Look here at the pre-contrast. Here. This is pre-contrast. Look.
Oh. So
What
it's
is this?
T1 hyperintense focus demonstrating faint enhancement. So likely this is hemorrhagic component within that
Yes.
lesion.
So this is, we should, before we mention this is solid or not, we should compare with pre-contrast.
Sir,
This
sir.
is just hemorrhage. Okay.
Hemorrhage.
So this is not carcinoma, mucinous adenocarcinoma, because there are no any enhancing leaf. Thank you, doctor, so much. See, my colleagues, this very clear case of torsion. Most of the signs of torsion. There are one colleague who was asking about the signs of torsion. Number one, very large ovary in ectopic position. Normally, you should see the ovaries here. Leave the mouse, please, doctor. Leave the mouse. Here and here, and next here. But here, it is very ectopic. Okay, what other ectopic location? Here, posterior to the uterus. Okay. Number two, look here, just inferior to this uterus, you will see pedicle twisting up on itself. Follow down. Okay, is it clear? Number three, in the contrast. Here in the contrast, my colleagues. What happened in the contrast? Completely non-enhanced. Completely non-enhanced. Okay. If you look here, this is the pedicle. Look, this is the pedicle. Swirl sign of torsion. This is a look. If you follow, you will see like tubular structure twisted upon itself. Okay, upon itself here. This one. At least we have many signs of torsion. Besides that, this lesion has no solid component at all, and I prove it to our colleague. It is just multi-loculated or multi-loculated. I think it is sensitive. The size of the cyst is more than 2 cm. So we are thinking in mucinous tumor. Search in any solid component, you will not find. Okay. Finally, the ovary is very dark, and this is not acceptable for the normal ovary. Okay, my colleague. So take care from, look here, this is the normal ovary, normal location, and normal shape. I told one of our candidate before, if you bring the stair especially, you will see very severe edema in the stair. I can define the stair, very characteristic. See here, there are some edema here, but I think in some types of torsion, some cases, it's very marked edema. Anyway, try to connect the history with the signs that you are seeing. Okay, my colleague, it was a neglected torsion, ovarian torsion. Not only torsion, neglected torsion. This is the ultrasound, by the way. Okay. And this was the MRI. Any question, my colleagues?
Is
for
it
today?
only neglected ovarian torsion or ovarian mucinous cyst adenoma leading to neglected torsion?
Yes, the more accurate, like you said, mucinous adenoma lead to torsion. This is the most accurate.
Sir,
Okay.
Sir, thank you so much.
Welcome. Any question, my colleagues? Thank you for your attendance today. Thank you. How to exclude torsion? I just mentioned, my colleague, again. torsion. Normally, you should see here in the adnexia, the normal location of the ovary, right or left adnexia, like the left ovary here. Okay, like the left ovary here. Second, any enlarged huge uterus like ovary like this, it is a suspicion of torsion. Search for other sign like this pedicle. This is very characteristic, my colleague. Look at this pedicle. Okay, look at this pedicle. What happened? This pedicle is twisted around itself. Best to pick up this one, especially in contrast. Look here. The ovary is totally non-enhanced. Second point, down, go down. I think in coronal better. Look here. Curvilinear structure twisted upon itself. Hey, look. Like any type of torsion or volvulus. Swirl sign, look. Some circles within each other. Thank you, my colleagues. Goodbye.